Afternoon. My name is Alexei Danilov. I'm a professor in the Department of Hematology at the City of Hope National Medical Center, and I'm joined today by Dr. Mazyar Shadman. We will be discussing some data that was presented at ASH annual meeting in San Diego in 2023, and I will ask Dr. Shadman to introduce himself and talk to us about Zanubrutinib and Acalabrutinib-Intolerant patients with B-cell malignancies, a study that he presented there. Thank you.
Hi, yes, my name is Mazyar Shadman. I'm an associate professor at Fred Hutchinson Cancer Center and University of Washington in Seattle, and thank you, Dr. Danilov, for having me. So the study we presented at the ASH meeting was from this ongoing trial that looks at patients who, with different type of B-cell malignancies, including CLL. Majority of patients actually did have CLL. 70% of patients had a CLL diagnosis. And these are patients who were receiving Acalabrutinib and were having good clinical response, but they had to stop Acalabrutinib because of adverse events. So the study basically provided Zanubrutinib to see what happens to the number one rate and number two severity of the side effects on Zanubrutinib. So this is basically a high-risk population for having adverse events. Acala is a great drug, and it's kind of not easy to have adverse events or side effects from it. So if you have a group of patients who had tolerance issues with Acalabrutinib, the question was what happens if they take Zanubrutinib. And I think a few highlights of this study, because we have published the original or initial results of it, but this is a long-term follow-up. Number one, this only focuses on Acalabrutinib because the study had a part that included patients who came off ibrutinib. So this is only Acala-treated patients. And the second point is that the exposure time to Zanubrutinib was twice as compared to exposure time to Acalabrutinib, meaning that if patients had average 5 months on Acalabrutinib on this study, their exposure to Zanubrutinib was 11.4 months, meaning that they did have enough time to show their side effects if they were supposed to have one. This was one of the questions we were getting with the initial reports of the study. And so basically what we reported is that, number one, most of the adverse events did not recur on Zanubrutinib. And if there was a recurrence of adverse events, none of the adverse events happened at the higher grade. So there were mainly, again, most of the patients did not have a recurrence. If they did, it was either the same grade or a lower grade. And, clinical responses will continue to be observed. I mean, I should mention that we did not require having an active disease going on this study. So if you were taking Acalabrutinib for a year and you have not much disease that's measurable, you would still be eligible to go on Zanubrutinib. Because of that, this response rate may not be as high as you expect, because if somebody comes to study as in the complete remission, they remain in a complete remission. We call it a stable disease. So it could be a little bit confusing, but the bottom line is that there was an excellent disease control, we call it. So these patients had disease control rate of 96%, meaning that if they came to the study with a PR or CR, they either continued to be there or improved their quality. And those who came on the study with a stable disease, the quality of response improved. I think the take-home message from the study is that while Acalabrutinib is a great drug, if there are patients who have issues tolerating it, Zanubrutinib remains a viable option. So we as physicians have the opportunity of keeping patients on this important class, which is a covalent BTK inhibitor.
Thank you, Dr. Shadman. I do think it's a very important study, and in my practice, I have switched patients with from who had some side effects on Acalabrutinib, which you noted are rare. I have switched such patients to Zanubrutinib, indeed, based on the results of your study. So it is for sure impactful, and it is reassuring to see that it would be okay to switch one BTK inhibitor from to another. But let me ask you a couple of questions. One is, are there any types of adverse events that would worry you enough that you will not go from one BTK inhibitor, say Acalabrutinib, to Zanubrutinib? Is there such clinical situation where you would say, you know what, I'm not going to stay with the class. I'm going to switch over to venetoclax or a clinical trial or something else?
That's a great question. And yes, there are such side effects. So in patients with major bleeding, and the definition could be, you could define it. To me, the clinically significant or concerning bleeding, I would try to stay away from the BTK inhibitors as a class if I can. If somebody has like internal bleeding or anything close to CNS, you don't want to risk, because at the end of the day, these side effects, yes, the incidence could be different, but these are considered class side effects. So if somebody has a bleeding problem that I'm worried about the significance, I would try to switch from the class of BTK inhibitors to something else, as you mentioned, BCL2 inhibitors and some other maybe upcoming ones. The other one would be, I would not. Atrial fibrillation is important, but it's common, and I don't see it as a reason to avoid BTK inhibitors. I think we can manage patients with AFib safely on any of these BTK inhibitors and treat the AFib. But when you get out of the AFib and you're looking at cardiac arrhythmias or any major cardiac issue, I would have a low threshold of, again, switching from BTK inhibitors. So anything close to ventricular arrhythmias or kind of any complicated arrhythmia, I will work with a cardiologist. Again, this is an important class, and we want to make sure that we're not excluding it from our options, but at the end of the day, safety is the priority. So cardiac side effects, some of them could also be a reason for switching, but not AFib.
Okay. Very interesting. Thank you very much. So obviously, like again, just to recap for the audience, if patients experience side effects on acalabrutinib, zanubrutinib can still be tried. What about the other way around? If you have a patient who has a side effect on zanubrutinib, do you think acalabrutinib can be used? Have you had such patients in your practice? I know that's not the study, but I am curious.
That's a great question. Have I switched from zanubrutinib to acalabrutinib? I may have had the patient. I don't have. I think I've done that in one patient. The study, as you said, is the other direction. But I would definitely, if somebody has intolerance to zanubrutinib, as long as it's not bleeding and it's not a cardiac issue, why not? I would try acalabrutinib, and these are different drugs at the end of the day, and if patient can tolerate it, I would keep them on acalabrutinib. So a lot of this is timing of the studies and approvals, right? So this could be a study in a different direction, but I don't see a reason why we can't do that in practice.
And so maybe last question. Say you have a patient who has, say, headaches on acalabrutinib. They try coffee, they tried, I don't know, Tylenol, vodka, whatever they tried, and it doesn't work, right? They still have headaches. And they come to you and say, well, I want to try another BTK inhibitor. So will you try zanubrutinib or pirtobrutinib at that point? Because both are kind of approved for that type of a situation.
Yeah, the first comment is like headache is a common and mostly shortly reversible side effect. I know you're using this example as an example, but headache is rarely a reason to switch from acalabrutinib, although we did have patients who had this prolonged headache that despite all the interventions persisted and they came on zanubrutinib. But in general, I try to kind of give enough time to keep them on acala. So that's the first comment. And would I go from acala as long as it's working to Zanu or Pirtu? I would try to stay on covalent BTK inhibitors and try Zanu. I think we know that pirtobrutinib has a reasonable efficacy, and we can talk about is it perfect or great separately. But we know that pirtobrutinib at least works for a reasonable duration of time after covalent BTK inhibitors. We don't have data for the reverse order, so I think from the efficacy standpoint, I would definitely exhaust my covalent BTKI kind of drugs before I move to the non-covalent BTKI.
Interesting. I'll say that I would do the same. Well, thank you very much, Dr. Shadman. This was a very enlightening discussion.
Thank you for having me.